Hello friends. Today we're going to discuss about delusional parasitosis. I'm Dr. Suresh Padadmat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be discussing about the evolution of delusional parasitosis, how to diagnose, the comorbidity, evaluation, and treatment of delusional parasitosis. Let's define delusion. According to Sims, delusion is a false fixed belief which is out of keeping with the patient's educational, social, and cultural background. Here, the belief is held with extraordinary conviction and subjective certainty. Delusion is also of morbid origin, is also an important criteria. In this background, let's understand what is delusional parasitosis. Delusional parasitosis is also called by various other terms, such as Ekbom syndrome, Morgellons disease, delusional infestation, parasitophobia, acrophobia, parasitophobic neurodermatitis, unexplained dermatopathy. However, the term delusional parasitosis was given by Wilson and Miller in 1946. Robert Willen in 1799 reported the presence of delusional belief of infestation associated with intense pruritus, that is basically scratching of the skin. Later, George Thieberg in 1894 described a similar case of parasitophobic neurodermatitis in which a patient with a delusional conviction that he has been infected with mites. Later, Carl Ekbom in 1938 reported a series of 8 cases that presented with delusional conviction to be infested with small organisms such as insects, dragonflies, fleas, spiders. Since he gave a beautiful description, hence this illness was also called as Ekbom syndrome. Further, it is also called as presenile dermatozoic delusion, or also it is called as delusional of animal life in the skin. The clinical picture was named after Carl Ekbom, so hence it is called as Ekbom syndrome, focusing on abnormal sensation experienced by his patient. Classically, the patient will say, as if something is crawling on the skin or under the skin. Burrs and Cornard in 1954 characterized this syndrome and also considered as chronic tactile hallucinations. Invariably, many of the young junior residents do believe this is a tactile hallucination. However, Monroe in 1988 suggested that delusional parasitosis may represent monosymptomatic hypochondriacal psychosis. Monroe also described this delusion invariably will be single, monothematic, fixed hypochondriacal belief without any other thought disorder. The patient's personality is well preserved and even cognitive function. Now let's define delusional parasitosis. Invariably, delusional parasitosis is a group of neuropsychiatric disorder characterized by the recurrent, bizarre delusional belief that one's body is infested by parasites, insects, worms, tiny organisms, or even unanimated materials such as ropes, hairs, maybe even wool, in the absence of objective evidence supporting their belief. Here, the important criteria is it should be monosymptomatic, that is single delusion, and it is persistent belief of infestation either with living an organism or unanimated things also be there. You can see this diagram where the commonest is the animate pathogens. It can be virus, it can be bacteria, it can be fleas, it can be worms. Inanimate can be sand, thread, fiber, and hairs. Invariably, the patient will feel something is crawling or certain sensation which makes him to believe either there are pathogens or worms or maybe thread or fiber which is creating this sensation. Here, the patient should have subjectively perceived this sensation which are realistic with high level of distress. The patients will go from one skin specialist to another skin specialist. That means they will meet the dermatologist. Patients usually feel they are not being taken seriously. Many a time they refuse to get engaged with regard to psychotherapy or psychiatric medication. They become disappointed and angry with the doctors who refer them to psychiatrists. Many of these patients will have tweezer sign. That is, they dig at their skin in an attempt to get rid of these fibers, threads, many a time even worms. Invariably, they also have matchbox sign. Here the patients will collect skin debris, clotted blood, broken hair, dandruff, fibers, cotton, wool, and other items, and they believe they are worms or parasites coming out of the body. And they put these small, all these in a small container or maybe in a matchbox to show to the physician. Hence, invariably, in earlier days, they used to use matchbox. Hence, this is matchbox sign. Many a time, it is also called as specimen sign. That means proof of infestation with parasites. And they bring these specimens. Nowadays, many patients use mobile phone video recording. Many a time, they also use lenses to get photographs whenever there is intense itching or pruritus. And recorded videos are common nowadays. And many of these patients, to get rid of this sensation, they will use excessive disinfectants, antiseptics, creams, chemicals, phenol, soaps, and various other chemical detergents to get rid of these parasites. This leads to excessive application of creams, sometimes insecticide creams, cleaning and washing rituals, and they try to scratch, and you can see itchy rash, flash, flaky rashes, peeling of skin, excoriations, and in the area, hair loss can be seen. Delusional infestation also may be accompanied with intense pruritus and hence the development of dermatitis artifacta. Here, the word dermatitis artifacta is when these patients with delusional parasitosis present in front of a skin specialist or a dermatologist, they believe this patient has some kind of psychiatric disorder and he himself is forming these skin lesions. Invariably, the patient scratch the affected part of the skin until the skin integrity breaks down, and invariably it causes breach in the skin, derma and epidermis, and use of various chemicals, disinfectants leads to damage of skin. And many of these patients invariably do self therapy. Invariably, it is also called as dermatitis artifacta because they are trying to get rid of these parasites from their skin. Many of them use kerosene. Many of them try to use burning charcoal to get rid of those worms, self mutilation with instruments, caustic agents, and heat. Invariably, the classical prototype patient is a middle aged woman. They will consult various skin specialists, and their main complaint is they are infected by parasites. Occasionally, you can also see their skin and other parts of the area of the skin. It may be scalp, which are injured, maybe dermatitis, pruritus, and these areas they believe that they are infected with parasites, larvae, flea, fungus, bacteria, viruses. Invariably, these patients' personality is well preserved, cognitive function is well preserved. Now let's look into the diagnosis of delusional parasitosis as per DSM-5. As per DSM-5, there should be presence of a single or monothematic delusion which is present for more than 1 month, and one need to rule out other causes of delusions. It can be schizophrenia, it can be various medical conditions, it can be schizoaffective disorder, substance use disorder, and invariably the central theme of this delusional parasitosis is there is abnormal sensation which has been attributed to various insects and organisms. The very important criteria is the patient do not meet the other diagnostic criteria of schizophrenia or psychotic disorders or mood disorders. And it should not be secondary to various any neurological, organic, or drug abuse. If you look at the difference between DSM-5 and ICD-10, DSM-5 says presence of one or more delusion which are monothematic should be there for more than 1 month, whereas ICD-10 talks about 3 months. ICD-11 does not give the duration criteria. They speak about many weeks to months. Invariably, DSM-5 gives scope to diagnose brief manic or depressive disorder, whereas ICD-10 talks about depressive symptoms or a full-blown depressive episode may be present in delusional parasitosis. Now let's look into the classification of delusional parasitosis. The primary delusional parasitosis is it is a persistent delusional disorder where clearly one delusion is there, that is delusion of being infested with certain insects. Secondary to psychiatric disorders such as schizophrenia, psychosis, acute psychosis, major depression, bipolar disorder, schizoaffective disorder, and various other causes. It also can be caused because of neurological condition such as cerebrovascular accidents, dementia, delirium, neurodegenerative disorders, cerebral neoplasms, multiple sclerosis, syphilis, meningitis, encephalitis. It is also seen in various drug abuse such as amphetamines, cocaine, hallucinogens, cannabinoids, and various synthetic cannabinoids. Further, it also has been noted in substance withdrawal like alcohol and benzodiazepine withdrawal, autoimmune disorder like LSE or lupus erythematosus systemic, endocrinological disorders like hypothyroidism, diabetes mellitus, neoplasms in colon, lungs, lymphoma, breast, various medications such as antibiotic, anti-Parkinsonism, corticosteroids, phenelzine, various stimulant drugs, and invariably other medical conditions such as hepatic failure, renal failure, leprosy, hepatitis, vitamin deficiency, and diabetes mellitus causing various polyneuropathy can also be present. Now let's look into how we make a diagnosis of primary delusional parasitosis. Invariably, the patient has the delusion of parasitosis, and immediately you look into the presence of any secondary involvement, that is, whether there is any organic cause or not. If it is there, then you will be considering it is an organic cause of delusional disorder. If there is a presence of other psychiatric disorder, it can be secondary to schizophrenia or acute psychosis. If it is present in another family member, and both of them have the same. It can be shared delusional disorder or it can be alone primary delusional parasitosis. Now let's look into the prevalence of delusional parasitosis. Although earlier epidemiological studies reported it is very uncommon condition that is rarely present. Female to male ratio is 2 is to 1 or 3 is to 1. That means females suffer more with the delusional parasitosis. However, the recent study by Bailey and his colleagues in 2014 reported the presence of delusional parasitosis is 2 per 1 lakh person per year. Other study by Corset and his colleagues in 2018 published in JAMA Dermatology reported 27 per 1 lakh person per year with a significant increase with the age of the person. That means in the geriatric population it increases. Let's look into the comorbidity with the delusional parasitosis. Depression is very common, dysthymia, anxiety disorder, substance use disorder. So one need to understand the DSM-5, ICD-11 usually do not allow the secondary presence of other psychiatric disorder. Invariably, even medical condition, neurological condition do not allow to make a diagnosis of primary delusional parasitosis. Now let's move into the treatment of delusional parasitosis. Invariably, the evaluation and management runs parallelly. It can be divided into 5 phases. Phase 1 talks about screening. Here, you will be listening to the patient. What are his chief complaints? You're not going to challenge him at this stage. Once you've done the screening, you may request for certain investigations. You may give a date for detailed evaluation. Once he comes for the detailed evaluation, you are entering into the phase 2. This detailed evaluation can be based on OP basis or inpatient basis. It is subject to the severity of illness and comorbidity. You can advise for admission. Please do collect collateral information from the family members and also ask for various documentation with regard to earlier consultation, investigation, treatment details. Further, look for the severity of the conviction. What is the extent it is impairing the patient's life? After the evaluation, you need to focus in the phase 3 of doing certain investigations, building rapport. Here, spend time with regard to discussion of what is the investigation you are looking for, why you have asked certain investigation. When you are asking for investigation, please explain the patients that what does it mean if it is a positive finding or a negative finding. And please do empathize with the patient, telling that they do have these abnormal sensations which are crawling sensation on their skin. Do not dismiss their complaint. Please empathize and say that they are very distressing and you are trying to do your best to help them. Phase 4 talk about how to initiate treatment. Here in this phase only the maximum dropout occurs because most of the delusional parasitosis do not have impairment in capacity. You need to take consent for starting the psychotropic medication. Invariably, many of these patients refuse to take psychiatric medication and they drop out. But however, if you are able to build the rapport, explain about the delusional parasitosis, and starting medications, especially psychiatric medication, will help. And if you are able to start medication, and once you start the medicine, you need to explain how long you have to take and how the improvement occurs. And final phase is maintaining the treatment. Invariably, the investigations asked are hemogram, inflammatory markers, ESR, C-reactive protein, liver function test, renal function test, pregnancy test, folate, B vitamin, HIV, syphilis, if they have vasculitis, allergy testing, and look for autoimmune diseases. If required, give a referral to the various other specialists. It can be dermatologist, neurologist, endocrinologist. It should be appropriate. Do not do indiscriminate referral. Patient may ask to talk to various other specialists. Please explain them and if required only refer them. Rarely, some studies have mentioned about getting punch biopsy of the skin, that is 4 millimeter. This needs to be asked by the dermatologist. Don't interfere in the dermatologist investigation or treatment. Very rarely, you need to do this skin biopsy. If the dermatologist thinks, yes, there is a parasites infestation, he may ask for this punch biopsy. But however, please do not do this skin biopsy routinely. If you look at the treatment, most of the patient refuse to take psychiatric treatment. Hence, the treatment adherence is very poor. Invariably, the patients having delusion, which are persistent delusional disorder, are very difficult to convince them to take treatment. However, secondary delusional disorders, especially organic in origin, you need to aggressively find the secondary cause and treat them. If it is epilepsy, you need to treat epilepsy. If the patient has head injury, look into the cause. If they have autoimmune disease, look into the cause and treat them. In this regard, there is a wonderful study done by McPhee and Kirchhoff in 2022. This study was published by in Journal of Dermatology and Treatment, published in 2022. The title of the study was A Systematic Review of Antipsychotic Agents for Primary Delusional Infestation. Let's look into this study. In this study, they totally considered 51 relevant articles were identified with regard to primary case of delusional disorder. Most of them were either case reports or case series. In this study, they found overall response was favorable both for typical antipsychotics and atypical antipsychotics. There was no substantial difference between either typical antipsychotics or atypical antipsychotics. That means the study being open label or maybe case reports or case series. Hence, it was difficult to compare head to head. Hence, this study also mentioned there is an urgent need to do placebo-controlled randomized control trial. If you look at the treatment aspects, one is medications, maybe antipsychotics, mood stabilizers, antidepressants. Rarely the patient, if they have suicidal ideas, you may consider ECT, and psychotherapy. Psychotherapy, it is either cognitive behavioral therapy or ACT treatment. There was an interesting study published by Variety and his colleagues in 2019, published in American Journal of Medicine. In this, they have given a treatment algorithm. In this, they have clearly said that the treatment option of delusional infestation or parasitosis, the evidence, whatever we have with regard to case reports or case series, indicates towards second generation antipsychotics. And this selective review also mentioned about the remission rate is up to 60 to 100%. Invariably, this delusional parasitosis is attributed to excessive dopamine. All the antipsychotics which causes D2 blocker has been used and found to be useful in case series. Second generation antipsychotics which are commonly used are risperidone or olanzapine. One need to give lowest dose possible because we have to treat them for longer duration. If the patient stop the medication, invariably the relapse of symptoms are well known. Recommended total duration of therapy has been approximately 6 months. By chance, if they relapse, you may have to consider giving treatment for over a period of 3 years. Further, if it is a second relapse, then you may have to give medication for longer duration. You need to consider stopping other medication which may be steroids, and other treatment. If the patient also have various dermatological issues such as scratching, pruritus, and various rashes is there, you may have to consider giving the referral to dermatologist and starting dermatological treatment. If you look at the evidence, the pimozide and haloperidol has been considered from the first generation antipsychotics, risperidone, olanzapine in the second, aripiprazole, ziprasidone, and quetiapine from the third generation antipsychotics. If the patient has pruritus, please do give them referral to dermatologist and consider various medication. It can be cetirizine, hydroxyzine, ointment, petroleum jelly can be considered. Similarly, with regard to Indian studies, there is a case series of 50 which have been reviewed. This study was published by Hebar and his colleagues in 1999 in Indian Journal of Psychiatry. The title of the study is High Prevalence of Delusional Parasitosis in Indian Settings. Here, they looked into the prevalence out of 4,234 patients coming to OPD of a psychiatry in during 1994 to 1997. They identified 45 patients with ICD-10 diagnosis of persistent delusional disorder, and the prevalence was of the delusional disorder was 1% and delusional parasitosis was 0.5%. Another, the recent study by Bhatia and his colleagues published in Asian Journal of Psychiatry looking into the delusional parasitosis, a clinical profile. This was published in 2013 in Asian Journal of Psychiatry. Here, if you look at the table, they did the review of 50 cases. The insidious onset is the commonest, that is up to 94%. The duration, if you look at the 6 to 12 months or more than 1 year, forms the major category. The area involved on the body is either on the skin of the body or the scalp. It is almost 40 and 60%. If you look at the psychiatric comorbidity, dementia, depression, and trichotillomania was common. This study, which was done in India, also looked into what are the different medications considered. The commonest medication being risperidone, olanzapine, and amisulpride. And if you look at the response rate is very high, and the complete remission also is very high, and partial remission, no responses is very few. This study clearly said that the second generation antipsychotics was found to be useful in 45 cases. The complete remission was noted in 60 to 75%, that is 29 patients out of 45 reported improvement. Cases while receiving various types of second generation antipsychotics reported improvement. However, only 20 to 25% reported partial improvement, and very 15 to 20% did not respond to any medication. Second generation antipsychotics such as risperidone, olanzapine, amisulpride, quetiapine, aripiprazole, paliperidone, and iloperidone has been tried. Study concluded that delusional parasitosis is a chronic psychiatric disorder, usually 6 months or more duration, with insidious onset, usually in the middle age. The primary persistent delusional disorder respond well to second generation antipsychotics. Hence, we need to give antipsychotics. Early diagnosis and treatment is very essential. The delusion that does respond to drugs and relapse occurs whenever the drug is stopped. Let's look into psychological intervention. In this regard, Katamanin and Jaffrin published an important review which was published in International Journal of Dermatology in 2023. The title of the study was Psychological Interventions in the Treatment of Delusional Parasitosis. A brief review. In 9 studies were included in this review. Partial remission was observed across all studies, irrespective of the treatment approach employed here. That means this study looked into whether addition of cognitive behavioral therapy or ACT, does it made any change? Invariably, This brief review did not find any changes between adding psychotherapy to the ongoing medication. This study clearly concluded there was no correlation observed between the incorporation of psychological intervention along with psychotropic medication. That means this study clearly said that importance of psychotropic medication, that is especially antipsychotic. However, most of the studies were open label and case series. There is no systematic studies available, no RCTs are available. Currently, the psychological intervention which are considered are either CBT, ACT, and family therapy. Here, most of these delusional disorder patients are difficult to engage in psychotherapy. Let's look into the course and outcome of delusional parasitosis. Another important study by Romanova and his colleagues, published in Acta Dermata Venerologica in 2018, which the title of the study was Longer Duration of Untreated Psychosis is Associated with Poorer Outcome of Patient with the Delusional Infestation. In this study, the researchers examined the association between the duration of untreated psychosis and the outcome of patients with the delusional infestation in multicentric study of patients with the 211 patients. In this study, they compared the duration of untreated psychosis with the severity of illness measured on CGI. Yes, that is Clinical Global Impression Severity Rating Scale. Lesser the rating is better is the prognosis. 0 is not assessed, 1 is normal, 2 is borderline, 3 is mild, 4 is moderate, 5 is severe, 6 is severe, 7 is among the worst patient. That means higher the score, worse is the patient severity. The results of the study was stunning. If the patient's duration of illness is less than 1 year, then the CGI severity was between 5 to 2 only. If the patient had a duration of untreated was 1 to 5 years, the rating was between 5 to 2. If the patient has more than 5 years, the rating was 5 to 3. That means the duration of untreated psychosis is very high, the chances of responding is very low. Here, the results are very crystal clear. Early intervention is desirable, especially in delusional parasitosis, for a better outcome. To conclude, my dear friends, whenever you suspect delusional parasitosis, that is, presence of abnormal sensation, the crawling sensation, and the patient says, I have parasites on the skin, immediately consider taking thorough medical history, doing thorough physical examination, getting some investigation, if required, asking for dermatological opinion, lab test, biopsies if required only. And if you detect parasites, that means it is true infestation, then let the dermatologist take care. If there are no infestation, that means we are dealing with delusional parasitosis. It can be secondary or it can be primary. If it is secondary, please aggressively treat the cause. And if it is primary, please do consider antipsychotics. And if the patient is depressed, please do add SSRIs. If you look at if the patient has secondary such as delirium, please refer them to the nearest emergency so that the cause of delirium is treated. If the patient is acutely intoxicated or withdrawal, please do manage appropriately. If the patient has OCD, please do consider starting SSRIs and therapy. To summarize, delusional parasitosis can be effectively managed by second generation antipsychotics. Although delusional parasitosis was considered a very rare disease, chronic condition, but available case series clearly indicates 60 to 70% of them respond to antipsychotics. At this point of time, we do not have data which indicates addition of brief psychotherapy. Will it help? Is a $1,000,000 question. We need to do research with this regard. However, at this point of time, available evidence clearly indicates the need for second generation antipsychotics, either risperidone, olanzapine, aripiprazole, or else you may consider pimozide, haloperidol can be considered. Thank you very much for giving your valuable time. Stay safe.